Hi, I'm Tasha. I'm a clinical research fellow currently in the final year of my PhD. And my PhD is looking at the relationship between pain and common mental health disorders such as depression and anxiety in patients with inflammatory arthritis. So my work is actually funded by the Keele uh, Academic Rheumatology Group and the Hayward Foundation. So thank you to those organisations. And just thinking about a bit about the background to the problem and pain and inflammatory arthritis. So the processing and perception of pain in inflammatory arthritis is multifactorial and arises from a complex interplay between joint pathology and the processing of pain signals from both peripheral and central pathways. So as we can see in the image on the left, this demonstrates that peripheral nociceptors are involved in pain processing in inflammatory arthritis. So peripheral nerve fibers detect various stimuli, so mechanical, thermal, and chemical triggers. And then the repetitive or intense stimulation increases sensory neuron responsiveness, increasing signaling. Inflammation that is central to inflammatory arthritis and driven by cytokines released from immune cells sensitizes these nociceptors, enhancing pain perception and inflammation at the periphery. The peripheral nociceptor stimuli transmitted to various regions in the brain, as we can see in the image on the right there, such as the thalamus, the somatosensory cortices, prefrontal cortex, and there are two brain processing networks, the affective emotional and sensory discriminative networks. And then you've got the modulation of sensory inputs, which occurs through the descending fibers that regulate the excitatory and inhibitory neurotransmitters and influence the balance of signals reaching the brain. So overall, what I'm trying to say is really pain is very complex in inflammatory arthritis and involves a number of different processes. So it's little wonder really that there's a massive burden of pain in inflammatory arthritis. And while there have been major advances in the treatment of inflammatory arthritis in recent years, pain continues to be a major challenge for these patients, with many reporting moderate to severe pain and rating pain as the health area they most wish to be improved. So looking at the graph on the left, despite treat-to-target strategies and high-cost treatments, still 79% of patients with rheumatoid arthritis in the BSR Biologics Registry suffer persistent pain. And in the management of pain, now moving on to the right, despite studies demonstrating little efficacy and potential harms with analgesics, patients with inflammatory arthritis are often prescribed opioids and gabapentinoids to manage their pain. As we can see from the graphs at the bottom there, analgesics are widely prescribed and there's been very little fall over time. We can see in sort of 2004 it was mostly sort of NSAIDs prescribed, and in 2020 it's more opioids. But this being said, so pain is a priority, and it's crucial we gain an understanding of alternative approaches to better manage inflammatory arthritis pain. Which is important to inform pain management in clinical practice and ultimately improve patient outcomes. And pain has been highlighted as a research priority, such as in the Versus Arthritis Pain Roadmap, that has highlighted there is a need for a better understanding between the link between pain and various comorbidities, such as mental health. And actually, EULAR guidelines for the management of pain in inflammatory arthritis recognises the need for psychological interventions and emphasises the importance of a holistic approach in managing pain. So thinking about depression and anxiety. So depression and anxiety are common in patients with inflammatory arthritis, and it's actually reported to be 2/3 higher than the general population. Studies report that in rheumatoid arthritis, depression and anxiety affect up to 66 and 84% of patients. And in spondyloarthropathy, depression and anxiety affect up to 40% and 30% of patients. And the forest plot on the screen demonstrates my point. So this is an adapted image demonstrating the prevalence of major depressive disorder in rheumatoid arthritis, measured by the CESTI, so the Centre for Epidemiological Studies Depression Questionnaire, which used a cutoff of 16. And we can see, while variable, the prevalence of depression in rheumatoid arthritis is high. But why is it important that depression and anxiety are prevalent in inflammatory arthritis? Well, outcomes with these comorbidities are far worse in these patients. So they associate with poorer treatment responses, lower quality of life, lower medication adherence, higher mortality, and higher medication costs. And while the causal pathways are unknown, potential explanations for the increased prevalence of depression and anxiety in inflammatory arthritis include established associations between depression and immune activation, and shared cytokine pathways between depression and inflammatory arthritis. And while there is a significant overlap between depression and anxiety, they are actually considered separate constructs, and therefore the relationship should be considered separately. So thinking about the evidence for depression and pain in inflammatory arthritis. So it's often considered that depression associates with worse pain in inflammatory arthritis, but the current evidence base appears conflicting. So first of all, on the left, looking at the evidence for the relationship between depression and pain in rheumatoid arthritis, Dickens conducted a systematic review and found in two studies there's some evidence the association between rheumatoid arthritis and depression may be attributed to pain. And Rathbun in 2013 evaluated the temporal relationship between depression and rheumatoid arthritis outcomes, and found one study reported baseline depression is associated with increase in pain VAS between 12 and 20 weeks. And Zhang in 2019 conducted a systematic review of cross-sectional data and found no differences in pain levels using the pain VAS, but worse bodily pain scores on the short form 36 in those with depression. Now moving on to the right side of the screen, and evidence for the relationship between depression and pain in spondyloarthropathy is much more limited. But Zhao in 2020 conducted a systematic review exploring mental health comorbidities in patients with psoriatic arthritis, and found in two studies comparing pain in patients with and without comorbid mental health disorders, pain levels were higher with depression. Moving on to anxiety and pain in inflammatory arthritis, and first of all considering rheumatoid arthritis in the evidence base. And that's on the left of the screen. So in 170 patients with osteoarthritis and rheumatoid arthritis, anxiety had stronger association with pain than depression. In a pooled analysis of 5 randomized control trials, depression was associated with a decreased probability of improvements of pain scores from baseline, but there was no association with anxiety. And matching in a systematic review of 4 studies showed significant associations between pain and anxiety. And now thinking about the evidence for the relationship between anxiety and pain in SPA. And again, we go back to Zhao's systematic review of 2 studies in psoriatic arthritis. We reported higher disease activity and pain with comorbid anxiety or depression. And this is highlighted in the adapted table at the bottom, in which pain levels were higher in those with anxiety and depression compared to those without. So looking at the effect of treating depression and anxiety on pain in inflammatory arthritis, and starting with evidence in depression, Prothero in 2018 published an umbrella review of psychological interventions in rheumatoid arthritis and reported small but significant non-sustained improvements in pain post-psychological intervention. And a Cochrane review, published in 2011, reported insufficient evidence to evaluate the efficacy of antidepressants on pain. However, these reviews did not specifically focus on the effects of treating depression and anxiety on inflammatory arthritis pain. And the evidence in anxiety is much more sparse, and the impact of pain, impact on pain of using psychological pharmacological interventions to treat anxiety is not well examined. So really, there's quite a few evidence gaps to address here, and some of the work we've been doing to address these evidence gaps is what I'm going to talk through today. And this includes a systematic review to inflammatory arthritis, define the associations between pain, depression, and anxiety, describe potential mediators of these associations, and evaluate the impact of treating depression and anxiety on pain. And then used CPRD data in patients with inflammatory arthritis, better understand healthcare utilisation in those with and without depression and anxiety. And we're going to be looking at describing analgesic prescription prevalence in those with and without depression and anxiety, and describing MSK pain consultation rates in those with and without depression and anxiety. And lastly, having looked at these problems, we're going to look at a digital solution to monitoring pain and mental health, specifically assessing the acceptability of electronic patient-reported outcome measures in routine inflammatory arthritis care, and understanding different factors that might accept this acceptability to inform its integration. So first, the systematic review. From 15,998 references, 79 studies were included. So this was 52 cross-sectional and 21 longitudinal observational studies with 6 RCTs. Studies were published from 1986 to 2023, and sample sizes range from 24 to 3,184 participants, with ages ranging from 27 to 65 years. So most of the studies were in rheumatoid arthritis, so that's 62 studies, 15 were in SPA, and 2 considered both RA and SPA. Most of the studies were relevant to the associations. 74 studies considered the associations. 2 longitudinal studies assessed the mediators of the pain-depression relationship. And 4 trials assessed the impact of treating depression on pain. Quite a few of the studies were considered to be at high or moderate risk of bias. So 35% of the studies were rated at high risk of bias, 34% at moderate, and 30% at low risk of bias. And just looking at some of the results. So first, considering the association in terms of correlation at a single time point or cross-sectionally. As demonstrated in the forest plot on the left, a meta-analysis of 34 studies demonstrated a weak to moderate correlation between depression and pain intensity. And then looking at the image on the right, a meta-analysis of 21 studies found a weak to moderate correlation between anxiety and pain intensity. And longitudinally, 2 studies demonstrated a weak to moderate correlation between depression and pain intensity. And in anxiety, 1 study found a weak, non-significant positive correlation between anxiety and pain intensity. But that was non-significant. So now looking at pain intensity scores in those with and without depression and anxiety. And first of all, looking at the image on the left, a meta-analysis of 15 studies considering pain intensity scores by depression status cross-sectionally found those with depression had higher pain intensity scores with a moderate effect size. And in the image on the right, a meta-analysis of 9 studies found those with anxiety had higher pain intensity scores, again with a moderate effect size. So looking at the associations in linear regressions, where depression and anxiety was the explanatory variable and pain intensity the outcome variable, and first considering the image on the left, a meta-analysis of 3 cross-sectional studies that considered depression found worse depression associated with greater pain intensity, again with a moderate effect size. And the image on the right was a meta-analysis of 3 studies, and it found worse anxiety minimally associated with higher pain intensity scores. And you can see that's a really negligible effect size. Longitudinally, of 6 studies evaluating the relationship in depression, 4 reported statistically significant associations, with higher baseline depression scores associated with more pain, changes in depression scores associated with changing pain scores, and mean depression scores associated with mean pain scores. 3 studies evaluated the longitudinal relationship in anxiety, and all of these actually demonstrated statistically significant associations with higher pain levels in those with more anxiety. So looking at the associations in logistic regressions, where pain intensity is the explanatory variable and depression or anxiety the outcome variable. And again, first looking at depression. A meta-analysis of 3 cross-sectional studies considering depression found more intense pain associated minimally with the presence of depression. So that's the image on the left. And on the right, a meta-analysis of 3 studies found greater pain intensity non-significantly, again associated with the presence of anxiety. So as we can see, the relationship is emerging, is more consistent with depression and sort of more limited and inconsistent with anxiety. So looking at the associations in linear regressions, where pain intensity is the explanatory variable and depression or anxiety the outcome variable, a meta-analysis of 4 cross-sectional studies considering depression found more intense pain associated with worse depression with a smaller effect size, and that's shown in the image on the left. And then in anxiety, 2 cross-sectional studies found with greater pain intensity associated with worse anxiety, and this had a moderate effect size. Longitudinally, of 6 studies considering the relationship in depression, again 4 reported statistically significant associations with changes in pain scores between visits associated with changes in depression scores, and an increase in pain associated with an increase in depression. Of 2 studies considering the relationship in anxiety, 1 reported a significant relationship between anxiety and pain intensity. So that was all in pain intensity, and looking at the relationship between depression and anxiety and other pain dimensions or specific pain types, and the data is much more limited. So 17 studies examined the association between depression and other pain dimensions or specific types, and the results suggest that depression is positively associated with neuropathic pain, maladaptive coping strategies, greater pain interference, lower self-efficacy, and lower pain acceptance. And 10 studies associated these relationships in anxiety. And again, the anxiety is positively associated with neuropathic pain, widespread pain, greater pain interference, maladaptive pain coping strategies, lower self-efficacy, and lower pain acceptance. That's the associations, and now moving on to the mediators of the relationships. And the evidence is much more limited. So there was actually no studies looking at the mediators of the relationship between anxiety and pain and inflammatory arthritis. And there was just 2 longitudinal studies exploring the mediators of pain-depression relationship. So one study looking at the mediators highlights the possible role of coping, and that's shown in the image on the left here, with higher levels of pain and more passive coping strategies leading to significantly worse depression. The other study found short-term fluctuations in positive and negative mood did not actually mediate the relationship between pain and depression. But it's clearly showing a sparsity of data in this area. So moving on to the effect of treating depression or anxiety on pain. And again, the data is limited. So there were 4 trials assessing the impact on pain of treating depression. And these were historical, with most trials published pre-2000 and one conducted in 2003. And looking at the data on the impact of treating depression on pain, and the findings are really conflicted. So McFarlane found that trimipene improved pain over 12 weeks in patients with inflammatory arthritis with depression, but mood didn't differ from the control. And Parker did not find that cognitive behavioral therapy in combination with pharmacological treatment for depression improved outcomes compared with pharmacological treatment alone. And 2 studies looked into the role of dothiopium. So one found treating patients with inflammatory arthritis and depression improves mood and pain outcomes, and the other demonstrated a clear analgesic effect of dothiopium in the absence of a significant reduction of depression or anxiety. But again, it's quite clear that more work and more contemporary work especially needs to be done in this area. Just summarising what we found so far. So there appears to be a bidirectional relationship between depression and pain intensity. While the evidence that anxiety and pain are associated is much more limited and inconsistent. Clearly more research on the mediators of these relationships is required, and there is some trial evidence that antidepressants improve pain in people with inflammatory arthritis and comorbid depression, but it does seem independent of their effects on depression. So moving on now to the CPRD study that I did. So as I mentioned, we were looking at healthcare utilisation, really comparing that between people with and without depression or anxiety. We did this for analgesic prescriptions and MSK pain consultation rates. So first looking at analgesic prescriptions, we looked at the proportion of patients receiving at least one analgesic prescription, comparing that in those with and without depression, with and without anxiety, and with and without mixed depression or anxiety. Then the analysis was conducted annually each year between 2012 and 2021, and it was separate analysis for rheumatoid arthritis, psoriatic arthritis, and axial spondyloarthropathy. So looking at the demographics, the population size is consistent with other studies. So for RA, we had the sample sizes between 57 and 78,000, psoriatic arthritis 26 to 28,000, and axial 8 to 11,000, and that's ranging between 2012 and 2021. As you might expect, there's a high proportion of females in RA, 70-71%. In PSA, females made up 51 to 52% of the population. In axial SPA, they made up 23 to 29%. And in RA, the mean age was 53 to 54. PSA, 47 to 48, and axial was a bit younger, 37 to 38 years. The proportion of those with fibromyalgia appeared to range between 2 to 6%. That's the coded diagnosis of fibromyalgia. So those with depression actually made up a very small percent of the populations, and this is due to the way that we define depression. So they had to have current depression. So to be classified as being in the depression group each year, they had to have a coded diagnosis of depression within the last 12 months. And that's the same for anxiety or mixed mental health, and they couldn't be in the other group. So they had to be in one group. So looking at some of the results, and analgesic prevalence in those with depression. As we can see from the charts, those with depression are consistently prescribed more analgesics, and particularly they are prescribed more strong opioids and more gabapentinoids. And this is consistent across the different IA types. There are some differences in basic analgesics, as we can see, and similar proportions of NSAIDs and weak or moderate opioids are prescribed. So yes, the way we did the analysis is we looked at the prescription of any analgesics and also looked by analgesic type, looking at basic analgesics such as paracetamol, NSAIDs, opioids, and classified these into weak or moderate opioids or strong or very strong opioids and gabapentinoids. Yeah. And while not graphically presented here, when stratified females, those with fibromyalgia, older patients, in both the depression and non-depression groups had greater analgesic prescription prevalence than the comparators. So interestingly, when we did this then in anxiety, supporting the systematic review findings, there seems to be a less of a difference in the proportion of those with anxiety and without anxiety being prescribed analgesics, and that's the same across the IA types. And the mixed mental health group follows a similar picture to the depression group. This is likely due to the depression component of the mixed mental health disorder. And again, strong opioids and gabapentinoids are higher in the mixed mental health group than those without the mental health condition. And again, while not graphically presented here, when stratified, females, those with fibromyalgia and older patients in both the mental health and non-mental health groups have greater analgesic prescription prevalence than the comparators. Okay, so that's the analgesic prescription prevalence. And moving on to the MSK pain consultation rates. So we looked at the rates of MSK pain consultation per 1,000 person years, comparing those with and without depression, anxiety, or mixed depression or anxiety. And again, the analysis was conducted annually each year between 2012 and 2021, and the analysis was separate for the IA types. So the demographics are very similar. The main difference is in the population size, and the difference was that for the analgesics, when looking at the proportions, the patients had to contribute a whole year of data, and that just wasn't the case for the rates analysis. And yeah, this is similar to previously. So looking at MSK pain consult rates in those with and without depression. So the rates are per 1,000 person years. And we can see that these are consistently higher in those with depression across the IA types. So in RA, there are nearly 3,000 in the depression group. The MSK pain consult rates are nearly 3,000 per 1,000 person years, so equating to around 3 consults per year in those with depression in 2012. And so it does have a downward trend, but it still remains consistently higher. And in 2012, comparing that to those without depression, it's just over 2,000 per 1,000 person years, so about 2 consults per year. And similarly, so you just follow that across. That's the same pattern in psoriatic arthritis. So in 2012, those with depression had around 2.5 consults per year compared to those without, where it was 1.5 in axial SPA. In 2012, those with depression had about just under 2.5 consults again per year, and those without depression had around 1.5. So then, yeah, again, we stratified that, and again, it's followed similar patterns. So females, those with fibromyalgia and older patients, both depression and non-depression groups had higher consult rates than the comparators. So again, looking at in anxiety, and the difference is less pronounced here. And we can see that there does seem to be some difference in the consult rates in RA more recently, but the picture is just much more inconsistent. And again, the mixed mental health picture is very similar to that of depression, and the stratification is really similar too. And again, that's probably due to the depression component in mixed depression and anxiety. So in summary, supporting the systematic review findings, proportionally more of those with depression receive analgesics, particularly strong opioids and gabapentinoids, and have more MSK pain consultations per year. So the healthcare utilisation seems similar between anxious and non-anxious groups, which again supports the systematic review findings. But clearly we need better monitoring and management of comorbid depression in patients with inflammatory arthritis. So just thinking of what we could do, I'm just thinking of a way we could do that, and a potential digital solution is collecting electronic patient-reported outcome measures. And we looked into this in the Hayward Arthritis Portal study. The Hayward Arthritis Portal study is was a study we conducted at our local rheumatology department, the Hayward Hospital, where we explored the acceptability of collecting and using electronic patient-reported outcome measures via a co-designed NHS platform called the Hayward Arthritis Portal in the routine treatment of patients with inflammatory arthritis. And we surveyed patients with inflammatory arthritis and their treating clinicians through a 10-minute survey. We selected a sample of these surveyed participants to be involved in around a 1-hour semi-structured interview. So just some demographics. So of the 336 patients completing the survey, most were female, of white ethnicity, had rheumatoid arthritis, had a mean age of 60 years, but around 40% were retired. A quarter were in the most deprived only quintile. A fifth actually had low health literacy, and around 1/5 lacked the digital skills required to independently use the internet, and a quarter had low e-health literacy as well. So we used the theoretical framework of acceptability to assess acceptability, and acceptability levels were high, with the majority rating EPROMs as acceptable or completely acceptable, over half liking or strongly liking EPROMs. Most felt completing EPROMs was fair or very fair. They agreed that they were likely to help their care, were confident in answering EPROMs, and agreed they understood how EPROMs helped their care, and considered completing them to be of little or no effort. But actually, global acceptability levels differed across a range of different patient factors. And there was a significant difference in global acceptability with age, with the mean age of, as you might expect, the mean age of people rating EPROMs as acceptable or completely acceptable being lower than those having no opinion or rating them unacceptable or completely unacceptable. And significant differences in global acceptability were also observed across patients by internet access status, general health literacy, and e-health literacy. But actually, the largest difference, as we can see in the digital skills Likert scale, the largest difference in global acceptability was seen by the digital skill level. Yeah, and whilst global acceptability scores differed across IMD quintiles, there was no clear trend, and gender and IA type didn't seem to have an effect. So thinking about the HCPs, we had 11 healthcare professionals completing the survey, and they were from a range of clinical backgrounds. So we tried to get a bigger range as we could. So we had consultant rheumatologists, specialist registrars, physios, clinical nurse specialists. They were aged between 30 and 60 years, were mostly female. And acceptability was high again. So all surveyed healthcare professionals rated EPROMs as acceptable or completely acceptable. They liked having EPROMs data and felt confident in using EPROMs data in routine care. Most agreed they felt it was likely to help patient care, were clear on how it would help care and felt it was little or no efforts to use the EPROMs. And the interview data actually supported the survey findings. Overall, patients liked using EPROMs. An example quote from a patient is on the screen. So I can just remember saying to my mum, "Oh, I'm ever so glad they've asked me these questions." So they're quite positively received. And healthcare interviews supported this too, with EPROMs perceived as being beneficial. However, as we can see from the quote on the screen, it's clear we need more work to effectively integrate EPROMs into routine care. So a healthcare professional thought, I think it would be helpful to have a more streamlined process for managing some of the issues identified, such as e.g. depression. I'm not an expert in this, and sometimes I feel uncomfortable asking GPs to deal with things they are already when they are already swamped. And also patient and HCP interviews demonstrated concerns around inclusivity and reflecting some of the findings that we saw from the survey. So in summary, there appears to be a bidirectional relationship between depression and pain, and more research on the mediators and impact of treating these comorbidities is required. There is greater healthcare utilisation in those with depression and mixed depression and anxiety. And these findings could be used to inform better management of depression and anxiety, such as improved monitoring of depression and anxiety and pain, maybe through digital solutions such as EPROMs. Could be used to inform targeted assessments for depression and anxiety in inflammatory arthritis, and help inform primary secondary care collaboration to manage these comorbidities. So just some acknowledgements and my references.